Welcome everyone to the first of 4 webinars on IPCP program evaluation, all of which are based on the National Center's Practical Guide number 5, Incorporating IPCP Team Assessment in Program Evaluation. 1 minute here. Here we go. The National Center for Interprofessional Practice and Education is a jointly accredited provider of interprofessional continuing education credits for the healthcare team. This statement describes the nature of this presentation and the 1 hour of continuing education credit that was available to those who selected that option at the point of registration. If you have questions about continuing education, please let us know in the chat box and we'll answer them at the close of this webinar. This slide states that our presenter, Connie Schmitz, does not have a conflict of interest in this presentation. My name is Angela Wilson, and I'm the Education and Training Manager for the National Center. It's my pleasure to introduce our presenter, Connie Schmitz. Connie is an educational psychologist by training, and we've been privileged to have her serve as a consultant for the National Center in areas involving measurement, assessment, and evaluation since 2014. She serves as chair of our Measurement Collection Advisory Board. Many of you already know her through her work on the Measurement Primer, the redesign of the Center's Assessment and Evaluation homepage, and our Measurement Instrument Collection. And now I will turn the ball over to Connie.
Good afternoon, everyone, and thank you, Angela. I'm so glad that everyone can join us. So today, we're going to explore some of the core evaluation design principles discussed in Guide 5. Our previous guides focused on IPCP teamwork and the assessment of individual learners, teams, or environments. And today, we build on that foundation, but we shift our focus to the programs that you all are designing to change the collaborative practice of individuals, teams, and organizations. Guide 5 could not have been written without the 3 co-authors listed here: Lori Collins from Thomas Jefferson University, Barrett Michalek from the University of Delaware, and Doug Archibald from the University of Ottawa. They will be giving the next 3 webinars based on Guide 5, and they will also be co-presenting with me this summer in a half-day course on program evaluation at the National Center Summit. And I know that you will enjoy interacting with them in the coming months. So why did we write Guide 5? Our purpose in writing Guide 5 was to help you do good evaluation work by writing an excellent plan. And by you, we mean people with some level of accountability for the IPE program and or expect to have some involvement with the evaluation. The guide has 3 main parts, as shown on this slide. And today we're going to discuss some of the things you need to think about or know before designing an evaluation, as well as some principles of design work relating to evaluation context. I hope by the end of the hour, you will first be able to describe elements of your own evaluation context that will impact your evaluation plan. Second, I hope you will have a more concrete idea of the role of evaluation frameworks and be able to explain some of the if-then type thinking that drives your program. Third, I hope you will be able to articulate several guiding evaluation questions based on a logic model and your stakeholder needs, and recognize how those questions influence the rest of your plan. So I based the agenda today on perhaps a risky assumption that many of you already have some evaluation experience or have begun reading Guide 5. I am therefore going to skip over some of the preliminaries of Guide 5 and focus mostly on examples. We will spend about 15 minutes looking at evaluation frameworks and deconstructing a logic model. We will spend another 15 minutes looking at 2 examples of plans that suit different types of programs and evaluation purposes. I will take maybe about 10 minutes to walk you through the 15 evaluation components of a well-written evaluation plan, as well as a planning tool. and then the remaining minutes are reserved for your questions. So, what is an evaluation framework? Well, you might say it is the conceptual scaffold on which your program and its evaluation should be based. Some evaluation frameworks are generic and can be used across broad genres of programs, such as education, health, and social care. Others evolve from fundamental understandings or theories about the nature of change in particular settings. For example, theories of learning and teaching, theories about innovation and their diffusion, theories about teamwork and safety, and theories about organizational change in healthcare. To develop a conceptual model for evaluating the impacts of IPE at the broadest level, the Institute of Medicine, now the National Academy of Medicine, convened a committee of experts in 2014 to review the literature on IPE and make guiding recommendations to the field. Their model postulates that IPE occurs throughout an extended learning continuum from pre-qualification / foundation learning to graduate education to continuing professional development. The model articulates intermediate learning outcomes for individuals and groups. It also includes more distal changes in health and system outcomes, which are shaped not just by IPE, but by enabling or interfering factors, such as professional and institutional culture, workforce, and financing policy. The National Center has adopted the NAM model as a guide for those of us who are evaluating programs and conducting research in IPE. I call the NAM model the MEGA framework because it represents at a broad level what the IPE-CP field as a whole is trying to accomplish. Individual program developers and evaluators, however, are not necessarily expected to do it all. But you do have to say which pieces of this bigger picture you are focusing on. You do need to explain more specifically how and why you expect your program to work. Before you can design an evaluation, you need to have a deep understanding of your program and be able to share that understanding with the evaluators involved. Specifically, you need to understand 4 elements of a framework that I like and have used over the years, which was developed by Daniel Stufflebeam, and it's called the SIF model. So let's take that model apart. Program context includes the nature of the problem being addressed, the background and history of your program, the education and practice culture in which it is to operate, the current status of IPCP knowledge or skills among the intended learners, and your assumptions regarding program efficacy. And these are just examples. It could be even a broader list. Program inputs include such things as your fiscal resources, your training philosophy, the level of administrative support you have for the program, and many structural characteristics of your program, such as those listed here. Program processes include what actually takes place during the intervention, during the program. And these are processes which you can observe and monitor during the evaluation. Up front, you may design some support processes with things like an implementation protocol or other methods of ensuring program fidelity. And this is really important if the program occurs across sites or classes. Implementation processes can also be supported by various platforms to support real-time communication, collection of assessment data, etc. And program outcomes, they range from immediate to long-term changes in participants and or organizations and or impacts on larger aims, such as those codified in the modified Kirkpatrick model, as well as the NAM framework. Most important, you need to have a good idea, and hopefully an idea based on a combination of research evidence and experience of not just what your program entails and how it operates, but why you expect it to work. What theories, what beliefs or assumptions do you have about the relationship between your program context, inputs, processes, and outcomes? Knowing the why is important because it becomes the stuff you need to investigate or test via evaluation. Theory-based evaluation can be thought of as an elaboration of the SIP model just presented. And this approach can be traced to the work of Carol Weiss and other evaluators in the 1990s, who challenged program developers to be super clear about their underlying beliefs, assumptions, or hypotheses about what drives change in their setting. Explicating program theory involves some if-then thinking, as in, if X occurs, then Y should be the result. And ideally, a program theory should present a logical chain of reasoning that explains why the program can be expected to work. And the logic model is the diagram, which is usually accompanied by a narrative explanation that illustrates that reasoning. Let's take a look now at how program theory and logic modeling play out for a fictitious program. And this program has been designed to improve family satisfaction with end-of-life decision-making in the surgical ICU. The context for this program is that end-of-life family care conferences in this particular SICU have been traditionally held by a surgeon, usually working alone, who then relayed directions to other care providers or staff. And this model led to some stress within the teams regarding the decision-making process, and actually disagreement over some of the actual decisions made and other aspects of care coordination. It also left the surgeon highly exposed to stressful encounters. Additionally, the SICU had also been incurring a small but steady number of complaints from family members and less than ideal ratings of family satisfaction on a standard hospital evaluation form. Surgeon and nurse leaders working with hospital administrators identified this problem as a quality improvement opportunity that could be addressed with a new approach codified by something called a team-based end-of-life protocol. And they proposed a training program to be evaluated by an internal team for improvement purposes. So in this protocol, multiple providers, that is the surgeon, the nurse, social worker, residents, staff, etc., attend the care conferences. Leadership for the meeting alternates depending on the situation and who knows the family best, and is collaborative in nature. The conversation is shaped by a shared philosophy regarding family engagement and the care team's role in asking questions, listening, providing information, and support. Introduction of this protocol into the SICU involves an initial series of meetings with team members. It then proceeds to a number of simulation-based training sessions based on real end-of-life scenarios, followed by a trial period and adoption in the SICU. And the desired outcome is greater family satisfaction with end-of-life decisions. So the operant theory of change is that family satisfaction with end-of-life decisions won't improve until the healthcare providers work as a team. That is, until they commit to using a new team-based protocol on a regular basis. But it's believed that neither providers nor the system will commit to change until a series of things happen, beginning with provider buy-in and ownership of the protocol, followed by positive experiences with using it in the simulation lab with standardized family members. Further, commitment to the protocol is believed to depend on how it affects provider and staff workload and stress. Does it alleviate it or compound it? Lastly, commitment is believed to be influenced by the amount of organizational and peer support for the protocol and whether usage leads to early success with families. So here is a logic model depicting that theory. And as you can see, it provides a deeper layering of the two main theories into a series of if-then propositions. It begins with overcoming provider resistance and building their motivation to change. If you look at the left-hand column of blue cells or boxes, you see that the theory is, given that providers are smart people who are evidence-driven, that their motivation to change will increase if they are exposed to data. Data in the form of A, feedback from their own family members that identifies problems, such as lack of communication and coordination, and B, positive findings relative to the protocol in the research literature. Most important, the model postulates that providers' motivation to change will increase if they are allowed to discuss and tailor the protocol to their own ICU. Assuming this happens, the model suggests that the providers will be more motivated to engage with simulation training. Providers will subsequently be more motivated to use the protocol in practice if the simulation training is of high quality. If you look at the pink boxes in the middle, you can follow along. Also, if they find that the teamwork approach does reduce stress, and if they get positive reinforcement from the standardized family members. And moving on to practice, the green boxes on the right, the model postulates that family satisfaction with end-of-life decision-making will increase only if the protocol is actually implemented and sustained by the hospital. For this to happen, not only is initial administrative support needed, but logistical problems need to be solved, and the providers need to feel support from a wider circle of colleagues. So each one of those if statements represents a key linkage that could be explored via the evaluation. So as you think about that model, what ideas does it give you about the evaluation? What do you think are the key assumptions or linkages to test? Having a logic model such as this provides a framework for what could be evaluated. It leads to questions that you want the study to address. And moving from logic modeling to evaluation design, let's think more about what you'd want to learn from the evaluation. What questions would you want answered? Based on the program's theory of change, you would probably want to know something about the nature and depth of provider and system buy-in. You would want to know more about family satisfaction and whether it increased over time as the protocol became institutionalized. From here, you could move to even more specific guiding evaluation questions, such as these listed here. And these would provide the starting point for your evaluation plan. And I'm just going to pause here for a few seconds and let you process these questions, and perhaps to think of a few others. Before we move to our next topic, I want to leave you with some clues for logic modeling. I find it best to start with the end in mind and work backwards. And the end might be a change in provider behavior or team performance, or it might be a quadruple aim. Then think broadly about what has to happen for participants. What has to happen for participants for change to occur? And for this, I use the literature in education, professional and socialization, etc., to help me delineate these if-then connections. As you build the model, you want to consider the key program inputs and processes that have to happen to motivate and sustain change. And lastly, do this exercise as a group with your key stakeholders. Doing that can be very illuminating to see if you're all on the same page. So I'm going to pause now just for about 15 seconds. To see if you have any questions, you can type in. I'll be addressing them at the end of the session. It also gives me a chance to get a sip of water. So let's move now to some General Evaluation Design Principles. Guiding evaluation questions are core. I'm going to say that again. Guiding evaluation questions are core, and they should be written to test key linkages in the program logic model. They are an important first step in evaluation design work. However, they are not the first step in planning an evaluation. And the first steps involve understanding the program context and purpose of evaluation, the stakeholders involved, their questions and needs, and how the results of evaluation are going to be used. The number and type of guiding evaluation questions to ask should take into account at least 3 important aspects of the overall evaluation context. First, the length of time the program has been around and its general stage of development really matter. For example, evaluation questions posed for a pilot program in its first year of operation are usually pretty different than those asked of a mature program that has been replicated at different sites. Second, the size of the program, its scope of training content, and intensity of training all really matter. Most specifically, these factors influence what outcomes can be expected. Smaller programs affecting fewer people, shorter programs, and those with limited intensity and duration should not be expected to change the world. In other words, they should not be expected to produce major impacts on health systems, for example. Lastly, your own resources and capacity to conduct evaluation matter. Evaluation can be very costly, at least in time, if not actual dollars. And having the right expertise on board can also enable more rigorous approaches. Now we're going to take a look at 2 fictitious evaluations designed for programs of different sizes at different stages of development with different purposes and evaluation capacities. We won't be looking at their entire evaluation plan. So these will be just sort of broad brush descriptions. My intent is to illustrate some of the design principles just discussed. For more in-depth coverage of sample evaluation plans, I really encourage you to turn to Part 3 in our Practical Guide 5. This first example, called Student Team-Based Program, is an example of an IPE program that takes place in an acute care setting. And I'm going to work through this slide. I apologize, I know it's a little bit busy, but sort of bear with me. So what is this program about? Well, it's a small program. It's operating at a single site. It involves 36 pre-licensure students who have been assigned to work as teams on 2 hospital wards. For 4 weeks, teams of 6 students, 2 nursing, 2 medical, 1 OT, and 1 PT, work under the supervision of a nurse facilitator to care for patients on rheumatology and orthopedic wards. The goal of the program is to develop student knowledge and skills about IPCP teamwork, as well as profession-specific competencies. So this is a pilot study. It's formative and exploratory in nature, and it's being conducted by a researcher who is external to the academic departments and hospital wards, but internal to the program team in terms of the planning, execution, and evaluation of the program. And the goal of the study is to improve the model before it possibly expands to other sites. The study goals are to better understand really the types of interactions that occur among the students during team-based care. It seeks to understand students' reactions to training and the extent to which a relatively short IPCP experience leads to positive student learning and retention after 1 year. The study also seeks to gain insight on the role of nurse facilitators and the impact of the program on their workload. This is an important question for the stakeholders. The program theory is the evaluation seeks to test a number of assumptions regarding interprofessional, team-based clinical learning at the pre-licensure level, including the extent to which it reduces stereotypes, deepens students' insights about their own and other professions, enhances their teamwork skills, and prepares students for collaborative practice. So what kinds of questions are appropriate given this program? Here are some sample evaluation questions that I've tried to make relate both to the program theory and to stakeholder needs. First, to what extent and in what ways do students collaborate during patient care? This is a very broad, open-ended question and posed that way for a reason. Similarly, what do students say about their experiences of learning and working together? Third, to what extent do students retain their teamwork, knowledge, skills, attitudes, and behaviors after 1 year? Fourth, what do nurse facilitators say about their experiences with teaching and supervision? And 5, how does facilitation style influence student learning and satisfaction? And I didn't go into depth with the methods here, just generally assume the methods include a combination of direct observation, interviews conducted pre-post with students and facilitators, and a 1-year follow-up student survey. I want to draw your attention to some key points from example 1. First, the evaluator is an expert qualitative researcher who is embedded in the program development team, providing literature on interprofessional student learning in clinical environments, as well as real-time monitoring of the program during the study. This is a great use of an external expert and an appropriate one for a formative pilot study when the student learning model is new to the clinical site. Second, based on the modified Kirkpatrick typology, one could say that this study focuses primarily on level 1, reactions to training. But it is not a simple satisfaction questionnaire, but a rich interview protocol with many follow-up questions that can probe aspects of the program theory. Third, the evaluation pairs self-report via the interview with direct structured observation of student interactions by the evaluator. Together, these methods allow for triangulation of the data and enable a much richer understanding of the nature and quality of student-to-student interaction, as well as student interactions with facilitators and patients. Lastly, by conducting a 1-year follow-up survey with students, the study gets at a key dosage question for course and hospital administrators, and that is, how much of a difference can a 4-week experience make? The 1-year follow-up survey could probe students' thinking about enabling or interfering factors that impacted their application of IPCP skills and behaviors after the 4-week course ended. Okay, now let's turn to our second example, student-led health promotion, which takes place in a community setting. Again, I apologize for the busy slide, but hang in there with me. So what kind of program is this? In this example, we have a 6-month community-based health education program for diabetic patients. 48 students from 2 universities co-teach patients weekly on a well-defined curriculum. In total, 4 clinics from underserved areas and about 100 patients are involved. The primary goal of the program is to improve patients' knowledge about diabetes and self-care and to improve their clinical outcomes. A secondary goal is to develop students' ability to work interprofessionally to improve population health outcomes. This is a summative evaluation designed to determine whether the student-led approach is effective. And the evaluation is being conducted by an external research team that has been working with clinical faculty for some time, studying student-led health promotion models The goal of the study is to determine whether the student-led approach to diabetes education and symptom control is as least as good as a traditional approach. The traditional approach entailing clinical providers offering pamphlets and talking to patients at the end of their visits. The secondary goal is to examine the effect of co-teaching the sessions on students' knowledge, skills, attitudes towards IPCT. In terms of program theory, the assumption is that if students are assigned to work in pairs to teach one-hour classes and to attend each class to provide ancillary support to their peers and answer patient questions, they will become more knowledgeable about diabetes and self-management and better able to teach and care for the patient population. As a result, the classes, which are supervised by faculty, will be effective in changing patient knowledge and self-care behaviors, which in turn will improve their clinical outcomes. So hopefully you've already been thinking of some evaluation questions for this program. And why don't you read yourself the ones that I've listed here and see whether you think they relate directly to the program and the study goals and the program theory. And again, I haven't sketched out the methods in detail, but basically let's assume this is a two-group intervention and comparison experimental study. And let's assume that the team has available to itself a number of existing tests and surveys with good validity evidence. And they're used to capture the information needed at baseline at the end of 6 months. So what are some key points from example number 2? Well, first, this evaluation, in contrast to the first example, builds on a whole line of research that's been focused on student-led health education classes with underserved populations. Among other things, this means that relationships among faculty and clinic providers have already been established, and they became well known to each other in the previous year when the approach and curriculum were being developed. Also, in the previous year, students who volunteered for the pilot study reported learning a lot about diabetes, as well as a lot about teamwork by having to co-teach curriculum topics to patients. So some of the first if-then assumptions had already gained some positive evidence. So because the previous year's evaluation provided some positive evidence regarding the student model, the goal of looking for impact of the model on patient outcomes in the current evaluation becomes more plausible. And again, because of the program's history, and also because the program's dosage of 6 full months, because the dosage was significant, the evaluation was justified in using an experimental approach to measure patient outcomes. Last but not least, the researchers were awarded a grant to conduct the evaluation, largely based on their early results and the fact they had a good handle on a theoretical model. Well, in summary, both of these examples that I've just described, they're both good because both are appropriate to their program's developmental stage and the size and scope of their interventions and the evaluation capacity of the team. Within my space and time limits, I tried to show the relationship between the type of evaluation being conducted and the program goals and the program theory, the study goals, and the guiding evaluation questions. Admittedly, I left a lot to your imaginations regarding context and implementation processes, but hopefully my essential point about the necessity of purposeful interconnection among these parts has been made. So I'm now going to pause again just for a few seconds to give you time to submit questions about these design principles. It also gives Angela a little time to start organizing your questions so I can address them in an organized fashion. Okay, so let's talk now about the actual evaluation plan you're all writing or revising. If you tuned into our February 8th webinar or have already purchased a copy of Guide 5, bless you, you know that by evaluation plan, we don't necessarily mean a lengthy dissertation, but a concise document that speaks to 15 components covering context, design, and logistics. Part 2 of Guide 5 is devoted to these 15 components, which, as you see here, are grouped into the 3 sections: context, design, and logistics. And as you scan this slide, several bullet points should be feeling pretty familiar to you based on today's discussion. So each one of these bullet points also represents a question you need to answer, the decision you need to make regarding your evaluation. Each one also represents a section of your written evaluation plan. So here's your format, folks, right there. And I'm going to give you a moment to digest these questions. To facilitate the design process, that is the middle set of evaluation components, we have adapted a planning tool first developed by Blaine Worthen and Jim Sanders. I think it's a really useful matrix. The column headers represent the design components of the plan. And on the left, under evaluation questions, you see the place to list your guiding evaluation questions. And then for each question, you then determine, you work through the rows to the right, first, the type of information that would best answer the question, then the source or sources for where you can get that information, then the method of collecting the needed information, and then the procedures for analyzing and interpreting the information you've collected. So the matrix may look like evaluation is this real simple, easy, linear process. However, that's typically not the case. Evaluation design work can be very iterative. However, working through the matrix can help you discover synergies among data collection methods, for example. They can help identify questions that are too difficult or too costly for your team to address. They can also help you prioritize among questions to best fit your evaluation capacity. And then, because I love examples, to give you just a brief example, this slide shows how one might complete the matrix for a guiding evaluation question from our fictitious evaluation for the student team-based care for diabetic patients example. So the question there to the left is, to what extent did student knowledge about diabetes and self-care change over a 6-month period of time? In this case, the evaluators decided that 2 types of information would help answer that question. And the first is they want to know how students would answer factual questions related to diabetes and disease management. And this could be ascertained with a multiple choice test that assesses students' mastery of requisite knowledge at 3 time points: pre, post, and delayed post. And the analysis would look at standardized change scores for the various time periods and use common statistical guidelines and tests to interpret the meaningfulness and the probability of the findings. The second type of desired information consists of faculty observations of the student-led instructional sessions with patients. So recall, students did all the teaching, so it would be logical for them to improve over time in terms of the extent and accuracy of the information they gave out and their confidence in answering patients' questions. Faculty documentation of student knowledge and confidence would be collected from a structured observation tool. And this largely qualitative data could be collected at baseline in month 1, at midterm in month 3 and in the final 6 months. The meaningfulness of the information could be established partly by triangulating the results with the pre-post knowledge test change scores, and also by conducting individual debriefing sessions with the students. In summary, there are many more details to work through in the written plan, but completing a matrix such as this can be very helpful for keeping the basic outline of the plan straight in everyone's mind, and for presenting and discussing the approach with various stakeholder groups. So I hope my talk so far has helped you think more about your own evaluation. What elements of your evaluation context are important? What are the key points in your logic model? What questions do you need to ask in order to learn what you want to learn, make decisions about your program? So looking ahead, if the timing is right for you, we hope you take advantage of the 3 upcoming webinars in this series to learn more about the application of this planning tool, as well as data collection methods and analysis. And if you haven't already done so, please register for 1 or more of them, and please consider buying Guide 5. In conclusion, we feel strongly that evaluation is essential for program health and well-being. Even if you never get an evaluation funded, just planning for it can help sharpen your program. It is also vital for the IPECPC or high-quality evaluation. So we hope you pursue this goal, and we hope that these sessions in Guide 5 make your job a little easier. Thank you for joining us today.